Thank you for joining us today on this episode of the Cancer Project podcast. I'm very happy to be joined by Ben Frank, a good friend of mine. He's worked in oncology since 2014, started at MD Anderson Cancer Center, one of the top-ranked cancer centers in the world, and we've had the privilege of working together in a number of areas, a number of locations. And today, he is an expert on all things insurance-related prior authorization as it pertains to accessing good cancer care. So we're going to talk about that along with just trends in oncology and cancer care going forward. Ben?
Very excited to be here.
Yeah, thank you so much for joining us. Yeah. So I want to start at the beginning. So 2014, you're at MD Anderson. Why did you go into oncology at that point?
Yeah, good question. So like many people, was affected by cancer early on in my life. Different family members had to experience that as a young child. But more importantly, when I was about 13, I had a blood disorder, pretty rare blood disorder, and ended up spending about better part of a year in an oncology practice, pediatric oncology practice, because the only oncologist or a hematologist in my community was also a pediatric oncologist. And just got to experience, what it was like sitting in a waiting room, sitting in an infusion suite with other kids that were going through cancer. I got to know a lot of those patients, became friends with them, and I just kind of sparked something in me then that I knew I wanted to go in oncology, and that's what drove me to pursuing a fellowship at MD Anderson. And so that's what I ended up doing.
So when you were doing the pediatric treatments, where was that?
So that was in Columbia, South Carolina.
Okay.
A small little hospital there. But basically my blood disorder was relatively benign compared to what those kids was going through. Yeah. So I had this weird experience where, my life wasn't in danger. I still had to go into this clinic on a weekly basis and sit there with them, but it was never as scary as it was for them. Yeah. So I got to see that from a different perspective by being a patient but not being scared, and got to almost see their fear and like talk to them through it as a teenager. And so it just had a lasting impact on my life.
Oh, I'm sure. Yeah. And so then you did an undergrad in business?
Undergrad in business, and then I went to grad school for healthcare administration at the Medical University of South Carolina. And one of the paths you can take when you're an MHA is to do a fellowship, which is a post-grad training at one of the big academic centers around the U.S. And MD Anderson is kind of one of the top locations to do a post-grad fellowship, and it was also cancer-focused. And so I really just honed my sights in there. And honestly, by just dumb luck, I got accepted to it. I wasn't even like the top candidate.
Yeah.
They pick 3 candidates every year to come into the fellowship program. I was ranked number 4 out of the cohort that interviewed, and one of the people ended up backing out. So just through, just luck, I got in. And so I think back on that a lot now.
And so what was it like being at MD Anderson? I've been there. It's an incredibly impressive campus. And it's also widely considered to be the top research cancer center in the country, and really, by many rankings, the world. So it must have just been a really neat and even awe-inspiring experience being on this campus with some of the top doctors in the country.
Yeah, no, it is. I mean, when you work at Anderson, you get to experience everything that an oncology center could experience over 10 years in like a 1-month timeline, right? So they have the rarest diagnoses that come there, and they have the top doctors that work there, and the best labs and the best imaging, and then everything you could imagine. And so, it's not realistic when you look at the community oncology setting to expect what you have at MD Anderson to exist everywhere, but I think we're getting better at that. But when you do work there, it's definitely awe-inspiring, and you kind of have to pinch yourself every day when you go into work.
What did you learn there that maybe was different or eye-opening as opposed to your experience as a patient in a hematology setting?
I think one of the first things I realized at MD Anderson I realized was going to be important throughout my career was the effect of a truly multidisciplinary care. Mm-hmm. When you have a surgeon and a rad onc and a med onc all working together, and even radiology and pathology together on a patient. And when I was, in Columbia, South Carolina as a patient just in hematology, obviously I didn't have surgery and and radiation oncology involved. I did have surgery later on. I had my spleen removed as part of my blood disorder, but those doctors never even really talked to each other.
Okay.
And it was just kind of like siloed in the community setting. And so when I went to MD Anderson, seeing that happen in real time and sitting in grand rounds and these kind of peer-to-peer conversations happening about different patients was just like, oh wow, this is a different way to deliver medicine, and it makes a lot of sense.
I understand why this is the top ranked cancer center in the country.
It makes a lot of sense. But now you start to see that in the community setting,
So then when you were at MD Anderson, did you have exposure to their Proton Center while you were there?
Yeah, actually, the Proton Center was my first introduction to radiation oncology. So when I was a fellow, the preceptor for the fellowship that year was Tom Buchholz. He was the physician in chief, and he's a radiation oncologist. So he did a really good job of connecting us in the radiation oncology division. And a guy named Matt Palmer actually was kind of like our partner in the fellowship program that really just kind of like showed us around the Proton Center, had us working on a project with him with letters of medical necessity, first introduction to insurance issues. And that is where my interest really just sparked. And then on top of that year, we had a fellow that was also a clinical resident, so a fourth fellow, and his name was Nikhil Thakur, and he was a radiation oncology resident.
Okay.
And so just got to learn a lot from him just by sitting like desk to desk, learning about radiation oncology and really just kind of absorbing it.
So that's interesting that you brought up insurance approval and prior authorization while you're at MD Anderson, because I would think if you're MD Anderson and you say that a patient or a doctor says that a patient needs a particular treatment, that's just an automatic yes.
Oh, not
Was
necessarily.
that not? No. So even at MD Anderson, they struggle with getting insurance approval.
Yeah, general rule of thumb is the larger the healthcare system, the more leverage they have with payers. And generally the easier the process, but it's not always a slam dunk. And there's always challenges. There's always diagnoses that a doctor prescribes something for and the insurance company disagrees with it. And at the end of the day, the insurance company is the kind of arbiter of these decisions, at least on the financial side. They'll like to say that it's not a clinical decision.
Right.
The doctor can still treat the patient with whatever modality they want, but there's a financial cost to that.
Yep.
And unfortunately, these insurance companies are really standing in the way of that.
What were some things that you learned about the process at MD Anderson that you took away and wanted to apply in the community setting? What were things that you saw that they were doing well?
Really breaking the process down in a militaristic format. I give a lot of credit to a doctor named Dr. Ash Shah. So he was a physician at the Proton Center that they hired. I believe he was at one of the payers before as a medical director. So he had this really deep knowledge on the process of prior authorization and utilization management. And he taught me actually later on at Provision, when he came to work at Provision, that you have to have a very defined process and you have to understand the regulations like the back of your hand. That comes down to federal regulations, state regulations, which differ, by the way, by payer. They differ by the type of plan it is. They differ by the location of the practice. And the way MD Anderson did it is just really understanding intricately every single case and following that process to a T. And that always results in better outcomes, better approval rates, better overturn rates for denials. And so that's one of the things that when you apply that in the community setting, you can replicate that success.
So then from MD Anderson, you moved to Nashville.
Yep.
So talk a little bit about that transition and how you ended up at the Proton Center there in Nashville.
Yeah, that was a big move. So weirdly enough, you are the reason I was in Nashville.
Okay,
so, my boss at MD Anderson at the time was sitting next to you, I think at a conference somewhere, Robert Gaffar.
Yes.
And he knew at that point that I was going to be moving to Nashville because my wife got a promotion to the corporate office for her company. And so I called you and you said that you were building a Proton Center in Nashville with Provision. And that's how I ended up there. I was, I think, employee number 1 at that location.
Yeah, no, that was very fortuitous, sitting next to Robert at a conference. I think it was the Race Search users meeting in New York City. I think is where I was talking to him. And for those of you not familiar with Race Search, they make a treatment planning software that we use in radiation oncology.
Very good.
And so, I was at a company called Provision Healthcare, and we had a Proton Center in Knoxville, Tennessee, and that center had opened in 2013. And I was the VP of operations for that center. And then that company made the decision to partner with, at the time, Tennessee Oncology and build a Proton Center in Nashville. There was no Proton Center at that time in Nashville. And so I moved over as the VP of Business Development to help get that project off the ground and get that center open. And then we knew we needed to hire somebody with a really strong operations background. And so, we had that position open. I think you started as the VP of Operations.
Yeah, something initially, like that. Or Director of Operations, something like that. Yeah.
Yeah, and we had, because we had Jim Gray as the medical director. So he was the radiation oncologist, kind of running things from a clinical throughput and clinical process standpoint. And then everything on the business side, we turned over to you.
Yep.
And we crossed paths briefly because that was about the same time that I left to go work on purchasing the Proton Center in Oklahoma City, the Oklahoma Proton Center. So what was it like? I mean, because you were in fellowship at MD Anderson. I think you maybe worked there for a little bit afterwards, and then now you've got this facility that you're in charge of.
Oh man,
what was that like?
It was a big move. Basically going from having a very siloed job at MD Anderson. I think when I left MD Anderson, I was over the capital purchasing and planning for the division of Rad-Onc, to basically being over everything for an entire practice. It was a big shift. And honestly, the biggest shift was just culturally. Startup mentality is very different than academic operations. And so, moving into a startup mode, Proton Center, it was just all hands on deck all the time. Lots of work, lots of time, lots of energy. And honestly, it was a lot of fun.
Yeah.
I think, I look back on that and I like to say, I learned a lot at MD Anderson, but I learned more about business working at Provision. And learned more about the business of oncology, the business of radiation oncology more specifically, and how to scale that. And what the kind of like knobs are that you turn on making a practice successful, like going out and recruiting, physician referrals or developing those relationships, going out and finding the right clinical staff, because, you're not MD Anderson. People don't just want to come work for you all the time. So you have to go do legwork and recruiting people. And so, I think it was definitely a culture shock at first, but I look back on it fondly. Like it was a really good time for me. And honestly, it springboarded me into my first company, learning, startups.
So, you bring up a good point about the staffing, because that's an overwhelm. It's one thing to say, okay, well, we have one open position, we have to hire a radiation therapist, we have to hire a nurse. We're gonna bring them in. We have processes already established. There's a culture already established. But when you're hiring everybody all at once, that is overwhelming.
Yeah,
and I remember, because I've been a part of helping open 4 Proton centers, and you're right. There's a lot of enthusiasm and energy. There's a lot that can go wrong. You're having to make quick decisions on the fly. Some things are going to work great. Some things are not. You also kind of have to go into it with a mindset of not everybody that you hire is going to be here 6 months from now, because there's people that are going to come in and think this is where they want to be, and then they decide it's not where they want to be. And so you have to navigate those challenges. You also got the first opportunity to take what you learned about the insurance process and getting insurance approvals and apply that at Provision. What was your mindset going into that? And what are some things that you think worked really well, and some things that maybe needed to be improved on over time? Yeah,
so when we started the Proton Center in Nashville, we actually took the model that was being used at the Knoxville Proton Center and applied it, which wasn't a bad process. They had a really good success rate, but through some conversations and some convincing, I convinced Shah from the Proton Center at MD Anderson to move up to Nashville to help run the Proton Center, and really reshape the way that we approach prior auth. And so that's where I really learned, like, okay, this goes a lot deeper than what we're doing right now, and there's a lot of opportunity to start overturning these cases. But I think in the private practice world compared to MD Anderson, you don't have that leverage that they typically did with the payers. So you're almost starting, behind the 8 ball a little bit. But nonetheless, we were still successful. We still achieved the same overturn rates that, some of the most successful Proton centers are getting at our, little private Proton Center in Nashville that didn't have any leverage and didn't have a lot of influence. And so it proved to me then, I was like, okay, there's something to this. Like this is something that every Proton Center needs to have access to.
So for those listeners maybe that haven't gone through something like getting treated for cancer and having to get insurance approval, go through the steps that a patient is experiencing along the way, and then maybe that what you were doing on the back end to try to get that approval, and maybe specifically in a situation where there's an upfront denial. So what does that process look like?
Yeah, so when you go into a consultation with your physician and they decide that they want to treat you with protons, the next step after that is getting authorization, approval from the insurance company to actually treat you with the prescription or the modality that the doctor has prescribed for you. And that process can be simple. It can take 3 days. It could be, hey, insurance company, we'd like to treat this person with protons. And they say, yep, you're good to go. And that would be a covered indication.
Okay.
When it's not a covered indication, take breast cancer, for example, in proton therapy, then they'll deny it. And unfortunately, a lot of physicians around the U.S. and a lot of practices around the U.S., when they get that denial, they just go back to the patient and say, I'm sorry, you were denied. You have two options. We can downgrade the modality to IMRT or 3D or whatever it may be, or you can pay out of pocket. And that can be devastating for a cancer patient. And that is one of the biggest things that motivates me is I hate that conversation. And I've had to have that conversation as someone who ran a proton center. And so when you can go back to that patient and say, hey, you got denied, but we also have this federally regulated process or state regulated process where we can appeal that denial, and we have multiple levels that we can appeal it, ultimately getting outside of the insurance company. Then it changes the mindset of the patient. Say there's still an opportunity here. And so what that process looks like is once we get the denial, we either have a peer-to-peer where the physician talks to their physician, and they're kind of hit or miss on whether or not you can be successful with them, depending on the physician that's on the phone. But the biggest step after that would be writing an appeal letter.
Okay.
And these appeal letters can be short. If you go to a typical practice around the U.S., they're probably using templates that are 1 page long saying, hey, I want to treat with this modality, and not really giving any context why. In our scenario, what we were doing and what was being successful is we were writing very long, detailed letters on why this should be approved, using research, using clinical justification, even like social factors with the patient's individual case on why they should be treated with any certain modality. And that appeal structure is what ultimately leads to the success. And so I mentioned there's 3 levels. So you have appeal level 1, appeal level 2, and IRO. And the ultimate success metric, in my opinion, is getting to IRO, which is independent review organization.
Okay.
And so what that means is that it's out of the payer's hands.
Okay.
And this really applies to certain commercial medical policies or insurance policies. But when you get to external review, you're supposed to be talking to someone who's non-biased.
Right.
That is looking at all of the facts on the table, the clinical case, the medical policy, whatever may be relevant, and they're making a decision on whether or not that should be covered under this insurance plan. And what we found is that if you build a story of appeal arguments over time, over that level 1, level 2, and then getting to external review, then the success rate at external review just goes up significantly.
Right.
It pays dividends to invest that time through the appeal process. And so that's where really the success of our program came from. And that's what Dr. Shah taught me is like, this is why you have to have a militaristic approach to this process. And so that's, it sounds like a lot of work, and it is.
Yeah.
But it
takes time. It takes
successful.
Resources. Yeah. So maybe let's use the breast cancer case as an example. So let's say it's a left-sided breast cancer. We're treating an area. We're treating the chest wall. Maybe it's after a mastectomy. There's lymph nodes involved. So that's a big area that's getting radiation, and it's a big area getting radiation in close proximity to the heart and potentially other critical structures like the lungs or esophagus. So that's a case that maybe for whatever reason, the insurance company doesn't have that on their coverage policy, meaning they're not going to approve every single left-sided breast cancer case. You're not going to get that upfront approval.
That's right.
But the doctor says proton therapy is a better option for a variety of reasons, whatever it may be. What is going into, when you talk about the detail, what's going into those appeals letters and those conversations with the doctors for that particular case?
Yeah, so for a left-sided breast case, we would bring in specific research related to dose to heart. Okay. So when you're using photons, sometimes the distribution of radiation to the organs at risk, or what we call OARs, can be significant enough that proton therapy is justified. Meaning, if we can use a different modality to avoid delivering radiation to the heart, which is near the left breast, then that is a good thing for the patient. And so the way we do that is we bring in research to show that, hey, there's been historical analysis done on multiple cases that show that we can reduce heart dose using proton therapy compared to photons. We'll also create a comparative plan. So during the radiation therapy process, there's a treatment plan that's created by dosimetrists. In proton therapy, a lot of times we'll create two plans. We'll create a photon plan, so an IMRT or 3D or VMAT, and then we'll create a proton plan. And we'll compare the two to see, okay, what is the dose being delivered to the heart in the photon plan? What is the dose for the proton plan? What is that delta? Is it significant? And then we compare that delta and those numbers to what's called Quantec dose limits, which is a kind of gold standard library of organs at risk and the kind of dose that you can deliver to that organ without causing significant damage. And we'll use that independent data to justify the modality.
And the heart is very sensitive to radiation.
Correct.
We know that.
Yeah, absolutely.
Also from clinical research.
Exactly. So there's a really famous study called the Darby paper, basically shows that there's a significant increase of cardiac event, based on the amount of dose that you receive to your heart.
So you've got this comparative treatment plan where you're actually taking the time, or this is the facility or their dosimetrists are taking the time to put together both a proton plan and a traditional radiation or photon plan and comparing the dose difference. And I guess there's a printout of images with dose calculations.
It's pretty. It's called a color wash. Basically shows the beams and how the radiation is being distributed across the body. And so we put that together for the insurance company to review and also the external review organization. And basically it shows them like, okay, clearly in the photon image, you can see the heart on the image and you can see dose going through it. And on the proton plan, you can see this great conformal distribution of dose and the heart's being completely avoided altogether. Sometimes that is enough to justify getting an approval. Sometimes it's not, because there's an argument that some dose to the heart is okay. Right. And that's actually true. But in some circumstances, depending on patient's anatomy, depending on prior radiation, it could be completely it could be a very bad situation for the patient to treat them with photons. And
so you mentioned also being patient specific.
Yes.
What do you mean by that?
The individual appeal letters?
Yeah.
So every patient's case is different. Their anatomy is different. Their specific diagnosis could be different. Their plan is different, their health plan. And so you can't just use a template to say, hey, I want to treat this left breast case with protons and use the same boilerplate language for every single case and expect insurance companies to overturn those denials. They want to see real justification on why this specific patient needs protons. Give me the reason to overturn this case is the way that we kind of see it from our side. And the only way to do that is to dive deep into that patient's case, understand why they need protons, understand dosimetrically why they need protons, but also from a socioeconomic perspective, they might not be anywhere near a photon practice. We've used those arguments in our appeal letters as well. And so, there's a lot of different variables. Another one is age. So protons being able to avoid organs at risk and delivering a, less dose to those organs. If you are a younger patient, you obviously have a longer life to live, definitive course of treatment, obviously. And what that means is that the late effects of the radiation exposure will not be experienced by someone who's older, but in a younger person, you may experience those effects. And so we use arguments for AYA, so adolescent young adult, all the time, and it's very successful. So if you're between the ages of 29 to 45, that's kind of that AYA area. And then getting outside of that, it's I think it's 19 to 45.
Okay.
But so like if you fall within that group, like I would say that you definitely need to be considering protons.
Yeah.
But there's a ton of different variables, and being specific about them is the most important part.
I think one of the things too that I've noticed reading some of the appeals letters that you guys have written is that you understand that it's not always a radiation oncologist that's reviewing all of the information, right? So preferably it would be, because a radiation oncologist would be the one that would understand all of these nuances that you're talking about. And so I think you guys always did a good job of saying, this may be a primary care physician or a rheumatologist or a surgeon or somebody who's not necessarily familiar with practicing in the field of radiation oncology. So we almost have to write it a little bit in layman's terms or explain things in a way that somebody who's not familiar with radiation oncology could understand.
Yeah. And unfortunately that happens not as much as it used to, but when we started in this process, it was not uncommon to be arguing against an ER doctor for a radiation oncology case that had obviously never treated with radiation for any of their patients, but had very little insight on what proton therapy was or what the difference between protons and photons were. And so, it can be extremely frustrating. And there's a lot of different variables on the payer side and barriers that are put up that are specifically, in my opinion, that are designed to dissuade people from pursuing appeals and make it harder, make it a more cumbersome process, make it bureaucratic. And so, what we did in my first company, Apollo, was we really just took that head on and we said, hey, we're going to be the antithesis of whatever they're doing. Yeah. We're going to fight fire with fire.
Yeah.
And that's.
So talk a little bit about that, because you were at Provision and eventually became the president of the Proton Center there in Nashville, but then really felt like there was an opportunity and a need, which is why anybody should start a company. There's a need and also a financial opportunity. So you left and started, and actually, I want to step back here because we had a conversation in Chicago. I remember that we were at a rooftop bar at Astro. So this is the big radiation oncology conference. And you told me that I had already left to go to Oklahoma, and you told me that you had this idea. And I said, go for it.
That was the start.
Why not?
That was the start. So that conversation kind of validated the concept. I remember asking you, I was like, hey, if this service existed, and this is what we could achieve, is that something that you as an operator of a proton center would want to engage with? And you were like, yeah, of course. Yeah. And so
why wouldn't we want to get more cases approved for proton therapy?
So that was the start of it. And, shortly thereafter, I my time at Provision was coming to an end, and kind of like learned as much as I thought I could learn there. And I knew, honestly, because of being in that environment, I was like, there's an entrepreneurial spirit inside of me that I wanted to just go out and explore. And so I left to start Apollo with my partner now, Chris Gonzalez. And so he and I just kind of started in our spare bedrooms, working on proton cases. You guys were client number one. And, it just started with an idea, and we really just adapted it over the next few years and took over a pretty good portion of the proton centers in the United States.
So I think it's, you brought up Chris. I think that was an interesting partnership because you had the business side, running a proton center, MHA, fellowship at MD Anderson, but he was a dosimetrist.
Yeah, so good point,
So why did you partner with a dosimetrist for this particular endeavor?
So getting back to, so Dr. Shah specifically, when he was teaching us about prior authorization, one of the key variables on successful prior auth is having someone who intricately knows the clinical side of the argument. And in our world, dosimetrists are the best kind of clinicians to take that argument on, because they're the ones making the plans. They know the dosimetry very, very well. The best way, for the patients out there and people watching this, the best way to understand a dosimetrist is to really think of them as the pharmacist for radiation. So they have this really deep, intricate knowledge of the science and the modality that they're delivering. And so if you can teach those people prior authorization and appeals, then they're really unstoppable. It's kind of best of all worlds. And so Chris was trained in this process and knew it really, really well. And so we kind of married together as just like this perfect partnership to grow Apollo.
Yeah, so you had this person that was familiar with actually making treatment plans. And I think this is important too. The dosimetrist is often the one that is helping to decide what type of radiation is the best way to deliver the treatment to the patient, meaning that they're the ones that are saying, this is the absolute best that I could do with an IMRT plan. This is the absolute best I could do with a tomotherapy or a VMAT plan, different ways to deliver radiation with photons. This is the absolute best I can do with a proton plan. And they're going to be able to speak as an expert on the ability to deliver radiation in the safest and most effective way possible. So you have this person. So then it was really just a matter of teaching this person how to write letters to insurance companies and follow a process.
And I can't take credit for that because it's not something I did. It's, something that Chris learned through his experience at MD Anderson and through Dr. Shaw. They really they spent a lot of time learning that process outside of dosimetry, but just understanding the insurance process, which is a specialty in and of itself. But yeah, you're right. Like dosimetrists, their skill set is really just optimizing plans. It's optimizing the prescription that the doctor writes. Once the doctor writes the prescription, they're drawing their targets saying, hey, this is where I want, delivery to happen. And then dosimetrist's job is to optimize delivery to that while avoiding as much healthy tissue as possible. And so they just get this really deep, intricate knowledge of like every single case. And if you take those people and apply it to the insurance process, who better to argue on behalf of the patient than the person that knows it the best, And so that's where it all started, and it ended up being very successful. And I would advocate for that in every specialty. Every healthcare specialty, you should have highly knowledgeable clinical people doing these appeal arguments.
Yep.
And I'm an administrator, that's my background, and not to sell administrators short, but clinicians are the best people to do this job, unfortunately. And it's a bureaucratic process, and in my opinion, it shouldn't exist, but it does exist. That's the reality. And if you want the best chance of getting those cases overturned, people that know the clinical details the best are the ones that are going to have the best outcomes.
I think there's like 3 pillars with this approval process for a patient. There's understanding the details of the patient's plan. And a lot of times practices or facilities will have financial counselors or financial coordinators that part of what their job is to look at the patient's plan and say, what are your in-network benefits, out-of-network benefits? Is radiation covered as part of your plan? What's the phone number that we're supposed to call? Is this an ERISA plan? Is it a state plan, et cetera? So is it a self-funded plan? So you have these financial counselors that are liaisoning or communicating with the patient about the nuances of their particular insurance plan. Then you have the person, and it could be the financial counselor, it could be the administrator like you, it could be the dosimetrist, but somebody needs to understand the regulatory process. Okay, well now we know what the plan is. Well, what are all the rules about the approval process that apply to that particular plan? And then there's the clinical aspect. And so those 3 things have to work in concert.
And if you could put them all together, that's the holy grail.
And that's what you guys did well.
Exactly.
So talk a little bit about some of the quirks or intricacies of the regulatory process. Like what are some things that you guys always had to keep in mind, whether it was from what the paperwork looked like or the timing of filing appeals? Talk a little bit about
the biggest thing from a so when it comes to regulations, the biggest rule that people out there that are looking at prior authorization and patients that are having to undergo it is ERISA. So if you have an employer-sponsored health plan, there are federally regulated processes for prior authorization for any employer-sponsored health plan. And that's a big chunk of American healthcare. I think it's 60% or so of commercial plans. That process in and of itself, when we started this, we realized that plans rarely followed the rules with ERISA. And it was because no one was, overseeing them. No one was calling them out on it. And so what we did on our side is we said, hey, these ERISA laws are pretty specific. So for example, if you have an urgent case, which we believe, most cancer diagnoses are urgent, so let's submit them urgently. You have 72 hours from every milestone. Every one of those appeal steps, you have 72 hours to return a decision to us, health plan. And what we were noticing is that they weren't responding in 72 hours. They might take them a week or more. But what we learned is that if you submit a denial on that 72-hour mark, or an appeal letter, on that 72-hour mark, even before you get the denial, and to say, hey, we notice it's been 72 hours, we're going to assume that you're denying this, but you violated the ERISA law. Here's the specific law that you violated. A lot of times they'll reach back out to you pretty quickly and say, this is now approved. Right.
Because the worst thing that can happen for an insurance company is to break the law. Like that creates a lot of liability for them. And I mean, you guys would literally write the rule or the law into the letter.
We'd make sure that all of the relevant information was in the letter. Whether that be the law, clinical research, even specific health plan clauses. So employer-sponsored health plans can have unique processes in and of themselves that are even more strict than what ERISA governs. So let's say, make up a company XYZ that has a self-funded insurance policy. and they're in Oklahoma, they can say, you know what, I want my insurance, I want my prior authorizations, I want you to have a response back to my employees sooner than 72 hours. They should have 24 hours. And so there's specific cases like that where, you have to know those things really, really well. And it's important to get your SPDs, which is a standard document that every employer gives their employees that outlines all of these things for their benefits. And then also looking at the health plan policy, looking at the medical policy. There's all sorts of rules that you just have to be really aware of when you're going into this process. And over time, if you have the same people doing it, then they remember these things.
Right.
So the bigger employers and the bigger health plans, they just know. And then they have direct lines that, hey, I'm going to call this medical reviewer for this case because, this is something I've talked to them about before in the past. And so you start learning those things, get a little tips and tricks here along the way. But timing is the biggest thing that helps us.
Well, and I think in taking advantage of what you talked about, that this really is an urgent case and there's rules about responding in a timely manner. Because one of the tactics that we've noticed that insurance companies will use is denial by delay.
Yep.
So tell me what that means in your world, denial by delay.
So prior authorization denials in the appeal process could easily extend out to 60 days, maybe even more, just simply from the insurance company not responding to your appeal letter. And what that means is that they're hoping that the case is so urgent. So it's cancer, obviously. Right. So you have to get the patient on treatment ideally as soon as possible, unless they're in watchful waiting or something like that. That the physician will become so agitated and the patient will become so agitated that they'll compromise and say, you know what, I'll just take a lesser modality.
Right.
And that is denial by delay. So we don't want that to happen. We want whatever the physician has prescribed to be delivered to the patient because that is the best course of action. But the insurance company, they know that if they delay things long enough that you won't have a choice. You'll have to take a lesser modality.
And then the insurance company can say, well, no, we never denied the case. Exactly. The patient chose to do something else.
They made a decision on their own.
Yeah.
I think that's 1/3 of all denials.
Wow. And so how do you combat that?
Speed.
Okay.
So it's holding them accountable to those timelines and then matching the speed. So if ERISA says every 72 hours, your timelines have to be faster than 72 hours.
Okay.
So you have to get those appeal letters out the door. And it's a lot of work to cram into a short timeline. But what we've noticed is that at first, the insurance companies are typically taken aback by our speed and the depth of our appeal letters. But over time, they start matching our speed because they know that we're not going to let them sleep on it.
Yeah.
And so that is the biggest factor when doing prior authorization is having a process laid out and then following that timeline to a T, and do not let it slip because you will have patients that fall through the cracks. You'll have patients that get too agitated and stressed out, and they'll rightfully so. They'll want to go either to another clinic or they'll downgrade their treatment. And then same thing with providers. Providers hate prior authorization. It's I want to say it's 99% or 98% of providers say that prior authorization is their biggest headache.
Yeah.
But yeah, it's you just have to have a really good process and follow those timelines because they will match your timing over time.
So you've spent a lot of time as you're navigating this process communicating with patients, and it's a high stress situation. Patient has cancer. They're potentially facing big medical bills. They don't know if the treatment that their doctor is recommending for them is actually going to get approved. And so, and just to put this in perspective, a course of proton therapy may cost $40,000, $50,000, $60,000. It might cost $100,000. It's a lot of money.
Yeah.
What are your conversations like with patients? What are you telling them to just help ease their burden a little bit going through the process?
Use a lot of data now because we have data that helps us understand what their likelihood of getting this overturned is. We did a good job in the early days of Apollo collecting all of that. Now with Unity, we have a digital platform that we can actually show patients hey, this is your likelihood of getting approval. But also staying in communication with those patients at every step along the way. Because what happens typically in a community setting is that there's usually one person working on prior authorization and they are completely overworked and overwhelmed.
Right.
And they don't have time to call every patient with every single update because they're in the community setting. They're trying to wear multiple hats and there's just a lot of workload. But with Apollo, what we did, we made it a priority is we're going to let every patient know every 72 hours what's going on with their case. And we're going to make sure that they know all of the details, the good and the bad. And that gives them enough information so that they can have relevant conversations with their physicians. And by the way, the physicians are also getting updates from us as well. So they are constantly in the know on what's going on. But I think that's really the only way that you can, that plus the data is the only way that you can really ease those stressors. But it's a lot better than not knowing anything, because in the community setting, you might not hear anything for a month. And when you have cancer, a month goes by, you haven't heard anything. I mean, just imagine the stress. It would be absolutely terrible situation.
Yeah, that and what you just described, that transparency and that regular communication, that applies on the clinical side, but it also applies on the financial side. There's this like financial diagnosis that comes along with the clinical diagnosis, and you want updates on the status of the financial situation. And you guys did such a good job of staying in touch with patients and communicating with patients and being very transparent. How have you seen, so shifting gears a little bit, AI is a hot topic right now. Yeah. So how have you seen AI impact this whole process? Maybe both on the positive side, you talked a little bit about data collection on your end of trying to get approvals, but maybe on the negative side as well, where there was a big case recently with United Healthcare where they got in some trouble for creating an AI platform that was automatically denying. There wasn't even a person looking at these high-profile cases. It was a software program that was making the denial. So talk a little bit about the impact that AI is happening.
Yeah, so I'll back up a little bit and talk about, in the early days of Apollo, we knew early on that we had to have a digital platform to scale the service. And so we started building something for ourselves internally, and we called it, I think at the time we just called it the Apollo platform or something, something really generic. Yeah. But we started building this system, and over time we started implementing automations into it, because to scale a solution that's completely driven by clinicians is really hard. And it's just not something that's obtainable for most cancer practices around the US. They can't afford to hire a full-time dosimetrist to do prior authorizations. Right. It just doesn't make sense. So we knew, like, okay, we have to take as much of the knowledge out of our heads and put it into a tool that can automate these steps as much as possible. And over time, our customers started seeing this system on grand rounds and other meetings, and they're like, hey, what's that thing? Yeah, I want to use that. Yeah. And so we commercialized Unity a couple of years ago, and we changed the name, obviously. It's called Unity now. But it's really leveraging AI to automate this process. And our vision for Unity is that in the future, not so distant future actually, this entire process, including appeals and all of those timelines that I'm talking about, will happen in the background while you sleep. So never having a human touch the process from end to end. And right now we have different pieces of that process already automated and using AI, including the appeal process. We kind of came out of the gate and said, the hardest thing is going to be writing these appeal letters efficiently and to the same quality that we're used to when we manually write them. But we just launched version 2 of our appeal tool, and it's the quality of the letters coming out of it is actually better than the letters that we manually wrote. So we've kind of crossed that threshold. Yeah. And so we're looking at voice agents so that they can actually have conversations with these payers. But you do bring up a good point. On the kind of flip side of Unity, you have these AI systems being used on the payer side. Yeah. And the biggest threat there, in my opinion, is when the clinical decision-making on the insurance side, which they don't call it clinical decision-making, they just call it utilization management. Right. When that is going to become automated, that is a scary thought for me, because right now it's a physician or a nurse reviewer looking at these cases. But, right now I think it's just rumors, and obviously the United case is a good example, but if there are tools out there that are being developed so that they can not use humans anymore, then it's the quality of those approvals, in my opinion, will probably go down.
Well, and if you think about the ultimate motivation of the insurance company, so let's take, again, going back to United Healthcare, because they've been in the news a lot, and they're also the largest commercial payer in the United States.
Big dog.
They're a for-profit company.
Yep, publicly traded.
They have an obligation to return money to their shareholders. That is a corporate mandate that they have.
Priority number 1, shareholder value.
Is to create shareholder value. The best way for them to create shareholder value is to deny coverage. Mm-hmm. It's to take payments for insurance plans and then limit the amount of that money that gets returned to their members.
Yeah, absolutely.
And so if you're United Healthcare or you're any insurance company and you're building a software program, probably you're building that software and you want it to be more efficient and do a better job than the people that you employed did. You're probably telling that software program, we denied X number of cases last year. We generated Y profits. We want X plus 10% denials this year. And that's just how they're going to.
And there's no talking back. There's no subjective physician clinical decision-making that goes on. And right now, whether or not there's good clinical decision-making going on with the medical directors with any of these plans is, questionable, just based on the fact that they're not putting radiation oncologists on radiation oncology cases. But you still have another human on the other end of the phone that, they have treated patients ideally in the past, or most likely in the past. And so there's a little bit of an emotional connection there that you can tap into, and there's a conversation that can be had. When you start leveraging technology to do it, it's just rule-based.
Yeah.
And there's no investigation into the nuances of each individual case. So it's definitely a little scary, but I don't think it will be successful in the long run for them, because at the end of the day, these plans need members. They need mass population to hit their revenue targets. And I think that there's so much pressure on them right now, especially in the prior authorization world, that their biggest customers, which are the employers, those ERISA plans that are using them as TPAs, they're going to start moving. They're going to shop around. Yeah. And because prior authorization is becoming such a prevalent topic in these sales pitches and these conversations, that employers are now starting to ask, hey, what's your prior authorization process? How do you deny patients? Like, if I'm an employer, a large employer, and I have 1,000 employees, and I'm looking at any one of these plans to use as my TPA, my first question to them is, well, all right, so what is your denial rate on standard of care?
Yep.
And because at the end of the day, those employees are going to come back to me, my benefits office. Right. They're going to look to me and say, why did you deny my care?
Right.
And I think that is something that is changing, and it has been changing over the past decade.
Well, and you bring up a good point. If there's going to be pressure on payers to not take the trend with AI or the utilization of AI too far, it's going to have to come from members, and it's going to have to come from employers.
Yeah, the customers. Yeah.
Yeah, and so educating those employers, because I've been involved in the past in the decision to pick a particular insurance company or a particular plan to offer to employees, and a lot of times at that decision-making point in time, you're just looking at the cost.
Yep.
What is this going to cost me as the employer? What is this going to cost my employees? It's important for employers to think about the downstream costs of having an employee who gets cancer, because it's going to happen. Statistically, it's going to happen. If you have 50, 100, certainly if you have 1,000 employees, somebody's going to get diagnosed with cancer at some point during their employment. You want that person to get the best treatment possible.
Right.
You want that person to have the fewest side effects possible. You want that person to be able to come back to work as soon as possible. You want that person to be happy with the experience that they had with their health insurance that they access through the employer. That's what employers should think about that.
Yeah, and they're starting to.
Yeah.
And the only reason I know that is because I took a side quest between Apollo and Unity to start a company called Wheelhouse. And it was a cancer-focused employee benefit, basically, that really just built a circle of emotional support and community support around patients as they were going through their cancer journey. And learned a lot about the benefits world building that company up. And one of the things that I learned more is that every year, employers are asking more about cancer. They're asking more about prior authorization, more about denials. So the more that we can educate them and really the HR offices and the benefits offices of these big employers, the more pressure will be applied to these big payers.
Right.
And so I think we're at kind of a turning point within our society. And there's obviously a lot of press about it right now too.
Yeah. No, and that's a good thing too.
Yep.
So what are you wanting Unity, this software program that you've built, what do you see it doing 2 years from now or 3 years from now?
Yeah. So ideally, our mission at Unity is to actually eliminate prior authorization. We want to collect enough data, build a streamlined automated process that we can go back to payers and say, hey, we have all of this information. You're denying 70% of our cases. We're getting 80% of those overturned. You're wasting money. We're wasting money. Let's just let's eliminate this process for this disease site. And then as we get more data for the next disease site, we do the same thing. So we can use that data to really start creating transparency, not only with providers, but with the payers, and with the goal of saying, hey, let's just have a fast track program. This is just slowing down care. It's not good for care. You're wasting money. Like, we can have an economic benefit here, and we can have a clinical benefit. And we truly believe that at Unity. And what we see long-term with our product is that we can be that intermediary. So we can be the data warehouse where payers come in and say, hey, we want to connect to you, and providers connect to you. And as soon as a provider has a patient that needs left breast protons, they submit it to the system, and it automatically gets approved to the payer because we have all of the data points right there ready to go and to transfer to the right areas. Right. So, there's a long way to go and a long road before we get there. And a lot of it is going to be collecting data and showing the value of a good appeal process to these providers and the oncology community over the next 4 or 5 years. But I truly believe that as we collect that information and we share it with the payers, that it will provide benefit to everyone.
Well, and payers want to be more efficient too. I mean, it's a cost savings for them.
Yeah, that's why they're looking at AI to do the review process.
Yeah, why go through an initial denial and a first level appeal and a second level appeal, and then it's got to go to external review, and they're paying doctors to look at cases. When it's just ultimately going to get approved at external review. Go ahead and approve it up front. Right.
Don't waste the time on it.
And you've talked as well about branching out into medical oncology.
Yeah, it's a kind of new area for us. We've been in radiation oncology for over a decade now, and my partners and I are all radiation oncology experts, but know really nothing about medical oncology, just the high level tip. But we do know that as these immunotherapy drugs and kind of patient-specific therapies are being developed, the denial rates are skyrocketing right now. And it's not historically, from what I understand, it's not historically something that medical oncologists have really stressed over, but it's becoming more on their radar. And as the cost of drugs, no surprise, goes up, the denial rate's going to go up with it. And we think that there's an opportunity there. And the benefit on the medical oncology side is that, kudos to medical oncologists, and maybe it's just the kind of nature of the beast, but they collect a lot better data than we do on the radiation oncology side. A lot more randomized trials and good clinical data that we can put in appeal letters. And so preliminary work that we've done there shows that our success rate is going to be similar to what we see in radiation oncology, maybe a little better.
So there's a pilot program that Medicare is implementing next year to actually do prior authorization. So historically, Medicare has had coverage policy. So they've said these are the services that are going to be covered. And we as providers know that going in. There's not really much of an opportunity with Medicare to go through an appeal process. There is, but it's rare that you would ever even try to pursue it. As complicated as the process is with commercial payers, it's even more complicated to try to appeal a Medicare
avoid
case.
the government at all costs.
Exactly. So for me, I'll just say, as a provider, this is a little bit frightening to think about Medicare deciding to get into the prior authorization game. What are you hearing about this, or what's your perspective on this pilot program that they're implementing and what it could mean down the road?
Yeah, I would be lying if I said I wasn't a little concerned about it. I think it's very surprising to me that the government's making a decision to add a utilization management program that has been plaguing patients in the commercial space for so long. But at the same time, I'm trying to remain optimistic that maybe they're going to try and implement processes there and tools there that will streamline it. And that implementation could be used in the commercial space as maybe even a regulatory kind of push to say, hey, here's our national prior authorization process. But there's still so many unknowns with it that it's kind of like just waiting and hoping that it's not going to be detrimental. But yeah, I mean, it's definitely given me a little bit of heartburn. Let's put it that way.
We are all a little bit nervous about how it's going to get rolled out and just what it's going to look like, because again, it's the thought of going through this multi-level appeal process with the federal government and all of the bureaucracy that exists there it's a little bit terrifying. So talk a little bit too about the changes in the way that treatments are paid for with radiation oncology? How have historically treatments been paid for, and what is the trend moving forward?
Yeah, so historically, the way doctors are reimbursed for protons or IMRT or whatever it may be is per fraction. So there's some ancillary services that happen before you start treatment, like your simulation or the treatment plan itself being developed, some consultations and doctor visits, things like that. But the primary bulk of the reimbursement happens when you come in for your treatment on a day-to-day basis, and every single day is a charge, is a individual, call it an invoice for layman's terms. And so that process can, if you have a long treatment course, that can add up to a lot of charges over time, and it can be very cumbersome, very complicated. And so what the talk right now within the government and within some commercial payers is that, hey, it would be a lot easier if we just started bundling these. And the other factor driving this is that Dr. A might treat prostate cancer with 20 fractions, and Dr. B might treat prostate cancer with over 30 fractions. And so there's also a nuance to it where these payers and the government are saying, hey, well, what's the clinical benefit here? If you have, intermediate risk prostate, same Gleason score, basically virtually the same patient, but you're treating two different ways, why?
Right.
And one's obviously significantly more costly to us as the payer. And so what is happening now is they're saying, what if we just gave you a bundle, one code for the entire course of treatment, or maybe just a few codes for the entire course of treatment, and you can do whatever you want.
Right.
You can treat with as many fractions as you want. You can treat with 5 fractions,
do it
20
in one
fractions.
Treatment.
Exactly.
Do it in 30 treatments. We don't care.
Whatever's best for the patient. And that is going to incentivize more efficient delivery of care, in my opinion. I think it's a good thing for our industry. It's going to create some growing pains, especially in the proton specialty. But I think as long as we can learn from it and carve out certain things along the way to protect the practices so that we don't have practices going out of business, then I think that it will ultimately be a good thing for patients. And it will be a good thing for the specialty as well, because right now it's just getting more and more complicated. We need to simplify things. So yeah, I mean, bundle payments are the future for sure.
Yeah, and I think it's important to talk about why there might be differences in the delivery of radiation. So historically, we didn't necessarily have all of the tools that we have today to be as precise with radiation as possible. And so you were delivering a lot of radiation to the body, you're delivering a lot of radiation to the tumor, but you're also delivering a lot of radiation to healthy tissue and critical organs. And so 20, 30, 40 years ago, the thinking was, to be able to safely do this, we need to deliver very small doses each day. We need to fractionate.
Over a long period of time.
Over a long period of time. There's a prescriptive dose. There's a total amount of radiation that we know eventually needs to get to the cancer cells to completely kill all of the cancer cells. But we need to spread that out so the patient can tolerate that delivery. As we've gotten more precise, both on the photon side, traditional radiation side, and with proton therapy, we do have more of an ability to deliver higher doses each day and the patient be able to tolerate that. And that's especially the case with protons because you're stopping that radiation inside the tumor. You're not getting dosed beyond the tumor. So there's just a lot less radiation that is hitting healthy tissue. But as you pointed out, because historically we've paid on a per treatment basis, if you deliver 20 treatments instead of 40 treatments, you're getting half the amount of money from the payer. And radiation oncology has significant capital costs. Proton therapy has very significant capital costs. A single proton room, even today, the total project may be $40 or $50 million. And so there has to be this kind of meeting in the middle where the payers say, we're agreeing to pay you a certain amount of money that's going to allow you to implement new technology like proton therapy. It's also going to be convenient for the patient. And then the doctor says, okay, well, this is going to allow us to hypofractionate, but also have a viable business. No margin, no mission. Meaning, if you can't cover your costs, again, at a proton center, you can't have the proton center exist. You have to be able to cover those costs. And finding that balance, it's going to be challenging, but I agree with you. I think it's best for the industry long term.
I think it's going to take some learning, but ultimately it's the right move, and it will bring down administrative costs as well. So billing for radiation oncology will become much simpler. And right now, billing is it could be 5% of your total revenue that you just spend on administrative costs just for billing, just for that one piece. And so, there's different areas where I think we will see advantages. The other thing is throughput. So if this incentivizes more hypofractionated, less fraction, less treatments per total course, then what that means is that any individual machine, any individual proton center can now increase the number of patients that you can treat at that facility. And if simultaneously you have an economic advantage and payers are buying on, ideally, then you can eliminate those kind of prior authorization issues. You can eliminate those access issues that currently exist and just start funneling as many patients as you can into the system. I think there will be some short-term pains there. Obviously, there's, it might indicate that we have more Linacs in the country than we need. But I think long-term it would be a good thing for patients.
Yeah, and and then there, to your point with that, there's the risk of some facilities shutting down, which creates an access issue, a local access issue for patients. And here in Oklahoma, we're, depending on the cancer diagnosis, we're somewhere between 48th and 50th. So somewhere between third to last, second to last, or last in cancer mortality, meaning if you get diagnosed with cancer in Oklahoma, you have some of the worst outcomes. But part of that is access. We're a heavily rural state. There aren't linear accelerators in some of these rural towns. So how do you still kind of create that access for patients? And I don't know what all the answers are to that. Certainly the payer reform and making sure that payments work for patients and for providers and for insurance companies, that's part of it.
Yeah. Physician coverage is another big one.
Yeah.
And that's a hot topic right now within our industry as well.
Yeah. Physician reimbursement is it's a big deal. You have to sufficiently pay physicians to deliver the care.
Yeah.
We need more people going into radiation oncology. We need more specialists. We need more medical physicists. We need more radiation therapists. There's a staffing shortage in radiation oncology. So just to kind of wrap up today, I think, we have spent a good part of our careers in the proton therapy world. I would say we're both pretty optimistic about the future of proton therapy.
Oh, yeah.
You would agree with that?
Yeah, definitely. I mean, just looking at the technology that's being developed right now, FIT system is a good example. What Leo Cancer Care has done with their upright system and Mevion coming in with their cyclotron is, it's really changing the game and changing the conversation on who has access to protons now as far as hospital systems go, as providers go. And I think as the capital cost and startup cost of these proton centers becomes lower and lower, you'll have more centers developed. There are centers being developed all across the country as we speak. But that volume will increase. And as we have more volume, we'll have more leverage. We'll have more conversations around protons. We'll have more physicians buying into proton therapy as a modality. And I think that's only going to be a good thing for us. And with that, we'll have more access to trials. We'll have more data. We'll have more disease sites being treated with protons. And hopefully, we'll have more access via the payers if Unity's successful.
And you've seen positive trends on the reimbursement side from a coverage standpoint and on the clinical research side as well.
From a clinical research perspective, yes. On the reimbursement side, I've seen positive advancements in the commercial space, surprisingly, in some geographic locations. But unfortunately, there's been some negative movement actually in my location in Tennessee with government reimbursement for Medicare reimbursement. So our MAC has changed their payment rates, have decreased them almost arbitrarily, pretty significantly. And it's, it definitely has an impact. And this kind of like hemming and hawing that we see in the reimbursement world is unsettling for sure.
Yeah.
But I think everyone, in my opinion, is just trying to wrap their heads around protons still, even though we've been around since the 90s, this modality. The volume of proton centers is obviously increasing, and the number of these utilization requests and prior auth requests going into these payers and claims going into the payers is increasing. And so I think everyone is just trying to say, okay, protons is becoming, it's got its foothold now.
Yeah.
Let's start putting some structure
Well, you were
it.
MD Anderson was what, Proton Center 4, 3?
I think 2 or 3.
Yeah. One of the earlier proton centers, and then Knoxville was the 13th proton center.
Yep.
I can't remember what Nashville was.
Somewhere around 30.
Yeah,
I think.
30. Yeah. I think today there's 50-ish.
It's approaching that number for
yeah,
sure.
getting close to 50 proton centers with multiple more in development.
Yep.
It very much is becoming a standard of care for a lot of disease sites.
Oh, yeah. Yeah. I mean, even if you look at like Louisiana, for example, they just passed a law, I think in the past year, that basically pegs commercial insurance medical policies have to be aligned with Astro model policy.
Okay.
And Astro's model policy is very generous, in my opinion. I mean, between group 1 and group 2 indications, you have a pretty large cohort of patients right there. As long as you have access to trials and clinical registries within your center, group 2 can, that's a big group of patients that you can tap into.
Yeah, and maybe explain that. So group 1, group 2, what does that mean?
So group 1 indications, Astra is basically saying these are great cases. They should be treated with protons. Group 2 indications are saying these may be good cases. You should use your best clinical judgment. And then if they're on a trial or on a clinical registry, let's study it. Let's open the door for these disease sites. And those are things like breast cancer and some other kind of what I would call controversial disease sites. But if you can get access to group 1 and group 2 indications in your proton center, that's a big deal.
Yep.
And so kudos for Louisiana for pushing that legislation through. And hopefully we can see other states doing the same thing, or even better, maybe these payers will start doing it, because we're definitely starting to see some Astro model policy language falling into these bigger payer medical policies.
It makes logical sense.
Yep.
Anytime there's no benefit to excess radiation to healthy tissue.
Yeah, no one wants it.
Nobody wants it. You can argue about the impact for a particular patient and could their body tolerate that excess radiation, but at the end of the day, there's no logic to only bad things can happen if you deliver extra unnecessary radiation to healthy tissue.
Correct.
So why not offer broad coverage to something like proton therapy? And then, as you pointed out, the costs are coming down to implement proton therapy. And that's going to just create more access down the road.
Yeah. Yeah.
Well, I really appreciate your time, Ben. There's not many people that understand the nuances of insurance and insurance coverage and the prior authorization process like you do. There's also very few people that are really legitimately doing something about it and working to try to create more access for patients. On behalf of the Oklahoma Proton Center, I want to thank you for everything you've done for us and everything that you're going to continue to do. And I'm really excited to see where Unity goes from here and everything else that you're going to do as an entrepreneur in this field.
Yeah, thank you for having me. And likewise, thank you for always trusting us. You're client number 1 for Apollo, so we owe you guys a lot.
Yeah, well, we want to be client number 1 for whatever's next as well. So, well, thanks, Ben.
Yeah, absolutely. Thank you.